Welcome to the Docs Who Lift podcast, where we distill and simplify the complexities of a healthy lifestyle, exercise, medicine, and weight loss. We're excited to bring you a podcast that's a prescription for clinical practice, scientific recommendations, and just real life. This is the Docs Who Lift podcast.
Hey, and welcome back to the Docs Who Lift podcast. I'm your host, Dr. Spencer Nadolsky, and I have my co-host, Dr. Karl Jr. with us. And today we want to get into this concept of lifestyle medicine and also the idea of food as medicine and exercise as medicine and all of that type of stuff. Basically, anything that has to do with lifestyle and just calling it medicine. So,
and how to incorporate it into our healthcare system better.
Yeah.
Rather than the way it's been done.
So here's what I think. I like the concept of lifestyle medicine, but in general, lifestyle is lifestyle and medicine is medicine. I think is what a lot of people, that's true. Some people, but from a marketing standpoint, now that I've gotten a lot into marketing and understanding, what kind of gets people ticking nobody cares about if you don't call it medicine, it's just kind of vanilla. So they kind of make it a little sexier by calling it, this is like medicine.
Yeah. Well,
that's what I think.
And also I think it then, to some degree makes sure that it's, in principle, it's prioritized to prevent or treat actual medical disease. Yes. Right. So when we say medicine, technically, it even includes surgery or whatever. Medicine is really healthcare. So it's kind of an interesting term in itself. Yeah. When we use medicine, it's not necessarily pharmaceutical medications per se. And so back in 2015 or so, when we were writing the lifestyle blog for MedPage Today, we had, I think it was 2 articles talking about how lifestyle or behavioral therapies are always first line for any type of disease process that can either be prevented or treated with improving lifestyle changes like nutrition therapy, exercise therapy, obviously smoking cessation, stress reduction, all that stuff. And so that's where it does really become important. And literally, you talk about marketing, we're the Docs Who Lift. We are shills for weight training and improving lifestyle factors and behavioral therapies. Easier said than done. But it is so critically important for everybody, for everyone's health, that it does need to be, addressed for every single person. And this will get into some of our discussion today because it really is for everybody.
Yeah. So in medical school, again, they kind of talk about these as first line treatment, but it's brushed over, and then you start talking about the pharmaceuticals,
right? Because physicians have to be experts in that stuff.
Right.
We need to know that nutrition, exercise, smoking cessation, stress reduction are critically important, and we need to always make sure that those are addressed. But physicians, our roles are to be experts in in medical therapy or surgical therapy or whatever that is. And so we also need to, think about how to incorporate this with our multidisciplinary team members, our dietitians, our exercise physiologists, our psychologists, behavioralists, etc.
So there is a push to create this specialty of, and there is technically an organization,
American College of Lifestyle Medicine,
to make lifestyle medicine its own specialty, to have doctors who specifically specialize in lifestyle medicine. And there are actually clinics around the nation that do only this. Is that right?
Yeah. And this is where I get on my soapbox for reasons that we'll get into. Well, because I've dealt with this in my healthcare systems, and trust me, I love the concept. We are lifestyle shills.
Yeah, we're pretty shills.
That's what we love. But it always ends up being these clinics that are not they're not primary care, which is where I think lifestyle medicine really needs to be emphasized, right?
Yeah.
They're almost like specialty cliniques a little bit.
Mm-hmm.
It always ends up being physicians with, whatever specialty as their baseline, like emergency medicine or whatever it is. And then they decided that, okay, they were like, well, hey, I want to quit dealing with all these people that are sick and whatever, and we want to go prevent it. Well, that's great too. I love that concept also, right? And then they get certified by the American College of Lifestyle Medicine, and now they have this clinic. And now it's a specialty clinic supposed to focus on helping people with nutrition especially, and we'll come back to this because they tend to have this little bit of a bias in the nutrition category, but they talk about physical activity, stress reduction, smoking cessation, all that
good stuff. Good things.
But my issue is that healthcare systems, from small clinics to bigger systems, hospital-based systems or whatever, to multidisciplinary or multi-physician groups, to bigger picture, nation and global healthcare systems, lifestyle as medicine or lifestyle behavioral therapy that needs to be first line. It's the most evidence-based stuff we have. It's in all the guidelines. We somehow have to incorporate that onto the front lines where people are. And that's in primary care clinics. People should not have to go to some specialty clinic, pay money that insurance doesn't even pay for, by the way, to get lifestyle counseling. That's ridiculous.
That is ridiculous.
And some of this comes back to insurance, by the way. I mean, insurance and whatever, our dysfunctional healthcare system, that's a whole nother podcast for another day. Like, it has to cover dietitians, exercise specialists, psychologists, behavioralists, all these people to help on those front lines. Primary care doctors can't even do it all themselves. Yeah, I mean, it'd be great if primary care doctors go and get some extra education in lifestyle medicine. But again, physicians should be using their expertise in real medical therapy. We have team members who are specialists in nutrition, exercise, psychology, all that stuff. So we got to find a better way to collaborate for people on the front lines. And some of this just goes back to how dysfunctional our healthcare system is, I think.
Yeah. I mean, lifestyle medicine, let's just be honest, it's not neurosurgery. It's extremely important. I'm not taking any.
No,
like you and I, that's what we do. That's
as important as it gets.
When I was in residency, family medicine, I was the lifestyle medicine guy, in the whole residency. And in fact, I've told the story before, but some of my attending advisors were kind of like, you're a little bit overzealous about this lifestyle stuff. And I was like, yeah, you guys are underzealous. That really upset me. I was so mad. I called you at the gas station and you're basically like, screw them. And I was like, yeah, I did. And then I won the Intern of the Year award.
Yeah,
I did.
because they came around and realized, oh, well, actually.
They did.
No, that's
they
true.
apologized. They apologized later. Because
it's true. And I do think actually throughout all my training, I think, I and even just we have always been, given props, I think, for our sort of obsession with pushing lifestyle medicine. But it also doesn't mean we need to be the fundamental, detailed, ones
coaches, basically the coaches.
Yeah, we don't need to be the coaches. We need to be experts in what we're experts in. I need to know endocrinology, pathologies, and be able to give treatment plans for people that are, medical, surgical, et cetera, in addition to lifestyle. And I need my team members to spend their time and their expertise giving those recommendations. And that's really kind of where my soapbox is. I just hate that it turned into this other little clinique thing that so many things do. It is so important for frontline.
Yeah. So this is where I think it's a system thing. I'm more of like, screw the insurance. I hate it. I hate insurance. I don't ever want to take insurance again. So I would say go the more direct primary care route of like some small subscription fee that just covers all of it. But again, not everybody might be able to afford that.
Yeah, this gets complicated.
But I also don't think you have to pay someone $500 an hour to get some very basic lifestyle. And there's some celebrity doctor type of people out there that you and I,
of course,
can make comments about that. They're charging millions of dollars. They get millions of dollars from patients, movie stars, and I'm like, oh God, you guys, you're not even getting anything like.
Right.
You're not getting any secrets. You're not getting secrets. I can promise you.
They're not even practicing real medicine that physicians should be known as experts in.
Yeah. So anyway, I do think we need to push lifestyle as medicine or whatever, just lifestyle in general. I don't care if you call it medicine or not, just lifestyle in general as a first line treatment. I think anybody listening to this probably agrees with us there. It's the key is how do we deliver it in a way that's affordable, accessible, equitable, whatever you want to say.
Yeah.
And then the other issue is the specific board specialty,
which is really the only one, because I feel like whenever in the systems that I've been in, and what I've heard about, anybody who has a lifestyle medicine clinic, it is like based on this, right? I mean, I don't know that there's anything else.
No. That's it.
And so then this is the other little thing. If you've listened to any of our podcasts, if you've followed the data, the literature, there are many different ways to improve an individual's nutrition habits, to lose weight, improve their cardiometabolic risk, fit their preferences, and whatever else, their backgrounds, their financial situation, and all that stuff. But the American College of Lifestyle Medicine does push sort of a very, very plant-based culinary aspect. And we've said before, everyone can eat more plants, and that's probably good.
Yeah, it's a good thing.
We know we want to minimize ultra-processed foods in favor of whole, minimally processed foods, which includes a lot of plants. But any of those other dietary patterns that you hear about. And I just made a couple posts about these because there was a meta-analysis showing that, Mediterranean patterns and lower fat patterns are the ones that have the data really to show like reduced cardiovascular risk so far. But we know that any of those types of things, keto, paleo, intermittent fasting, they can all be a little bit more plant forward. There was another study I just posted today where they just talked about how a pescatarian diet, which is kind of it's essentially plant-based, but includes fish, is maybe the best as far as when you use those healthy index scores. But again, those are imperfect. But a lot of it is, carbon footprints and its ideology, which is not necessarily right. And that's the thing. So what I end up seeing is that my patients end up coming to see me and they saw somebody at one of these lifestyle medicine clinics and they're all disgruntled because they're like, well, I don't want to be a vegan or a vegetarian. And I'm like, I know that's,
they're not.
I don't know what to say because I don't want to attack these people because I know they mean well.
Good. Yeah. It's overall good. If you're eating more plants, that's a good thing. But if you're not inclusive of other dietary patterns that may contain, animal products that probably aren't as harmful as other people are making them out to be.
I don't have any patients who want to be vegetarian. I'm sorry to my friends and colleagues that I've worked with over the past several years in these different systems who have the lifestyle medicine clinics. The patients are getting mad. And there's not really, and this could be another podcast. There's not an absolutely great reason for people to do that. We can talk about maybe the environmental things. That's a different issue though.
Ethical, if you want to look at ethical.
Whatever. The health advantages though are if we make all the different changes and make individual improvements very nominal. I mean, we've talked about how, low fat quality beef included in a Mediterranean diet has good data for cardiometabolic health. If we take a keto diet that has a little bit more of a Mediterranean pattern, that probably has really good cardiometabolic health, rather than drinking butter and eating all the saturated fats they can find, eating more nuts and seeds and olive oil and fish. That's pretty good. And that's kind of plant forward. I mean, even paleo talks about eating nuts and seeds.
Yeah, but for some reason, the paleo world got it. They
don't like legumes, and they got into. They got
weird
for some. Yeah, I know they got weird, and so they kind of fell out of favor, anyways.
Yeah, nobody even talks about paleo anymore.
The concept was, it's kind of whole food, whole food, natural whole stuff,
food, but lots of plants, and then they started eating butter, which has nothing to do with okay, this doesn't make any sense.
Yeah, and bacon. It's like,
I'm
pretty sure the cavemen weren't.
They were not eating bacon.
Preserving bacon, God,
and drinking butter.
Anyways, my request to those people who are even doing the lifestyle medicine is don't be so zealous with the vegetarian push,
the strictly plant-based push.
Yeah, we got to individualize dietary therapy for people. And I swear to God, I don't have any patients who want to go. I have like one or two. Out of God knows how many thousands of patients. So they don't want to do that.
Yeah, you got to be patient.
If they eat fatty beef, we're going to try to minimize, maybe reduce it and make it low fat beef.
Yeah, if you want to switch some up for some lentils or something once in a while, great.
We're shills for lentils. Or that's a paleo doesn't like that though.
No,
for some reason, even though there's a great data for lentils, pulses, beans,
it's ridiculous.
Doesn't make any sense.
Well, so then let's go to the idea of food as medicine, because that's this almost idea of hyping up food more than what it really is.
Right.
So like the concept of superfoods, like improving someone's, like reducing the risks of cancer and these types of things. I think it depends on what you substitute something with. It depends on the total energy balance. And we agree that dietary patterns are very important for these things, but should we be calling food as medicine?
Yeah, I don't know. I think that's pushing. That's pushing it down a relatively slippery slope. I mean, again, we love the concept as really focusing on that, but unfortunately, what happens out there, sometimes it's
weirdos.
Doctors. Yeah, it's the gurus. It's
Mark Hyman.
Mark Hyman. Yeah, Mark Hyman. So he's a physician. He's famous. He makes billions of dollars. Cleveland Clinic even hired him to make them money, and all their doctors that are evidence-based hate it. And and he makes claims that specific foods somehow have effects that are as powerful as some of the real pharmacotherapies we have, when really, that's not true. We don't have that great a data, other than say the Mediterranean data, which are like nuts and seeds and olive oil. But even that, it's still that's a slippery slope.
Then villainizing certain other artificial sweeteners, for example, is
without any data,
common one.
No data to villainize some, but then they hype up others. Generally in some money-making scheme, it seems like. So
it's it comes back to marketing. He's a very good marketer. He is and a few of these other doctors. And like the thing is, it's like I could probably do some of that stuff. I know I could do that and become like a very wealthy guy, but it's not, to me, it's not ethical.
Well, of course not. Do you realize when I was in med school and I graduated, and it was already starting, because everyone could kind of see that in us, right? We were lifestyle, we had this sort of image, and people were very worried we were going to go off the deep end. I mean, I could see it all the time. People would say things like, whatever. And I got to say, I don't know. I would never do that. I think
you can't overhype something like whatever. Like, okay.
It's also why we lost out on berberine. Our one supplement we developed had a really good evidence base for a few different things, but we didn't overhype it because that the evidence wasn't there to overhype.
Well, and we also are it's not ethical. It's just,
that's what I mean. So then the quacks took it and ran with it, and we lost.
Oh yeah. Yeah, it turns out we're not that good at business, but I'll keep trying.
Or being quacks.
I keep trying. Yeah.
Well, you don't try to be a quack.
No, quack. So food as medicine, and then there's exercise as medicine, which we're I like. I don't mind the concept of it, because it almost, if you're, as opposed to adding a food in, if you add an exercise, it actually does have medicinal.
It's more,
I would say more medicinal effects. I think.
Yeah, it's more, and it's also more prescriptive.
Yeah,
probably right. So if we add in resistance training, there are very definitive benefits that people get from that. If you add in aerobic exercise, non-exercise activity, that's why those are as strongly solidified in all the different guidelines where they're relevant as it gets, because it's very prescriptive.
I love broccoli and I love blueberries, but if you add in a cup of blueberries today, I don't know. I'm not so sure there's going to be. Maybe it'll.
Right, and there are other. I mean, there are tons of berries, tons of fruits.
Yeah,
all that stuff.
Exactly.
There's tons of healthy foods. You don't have to eat one specific food to get like the benefits of it. That's what's crazy. So exercise is more prescriptive.
So my friend Kevin Davey, if he's listening, I don't know if he's listening, but he always says, why don't we just call instead of exercise as medicine, just exercise as exercise? And to me, again, it comes down to like a marketing thing. I don't know. How do we get people to exercise? We want people to exercise.
Yeah, right.
I don't know.
And the American College of Sports Medicine really has pushed this exercise as medicine.
That was when I was in med school, program, 2007.
And it's still going, and they're still pushing it. And again, I love the concept. So I think exercise as medicine is more
more along
aligned
lines than food as medicine.
Just purely based on definitions and grammar. I don't know, language. I think semantics. So
yeah, you could argue that like food could be medicine, but I think because you could reverse type 2 diabetes, you can do this and that, but it's like a lot of it just is energy intake in general.
Right.
So like if someone's eating whatever 4,000 calories worth of like a relatively healthful dietary pattern, and they have type 2 diabetes, let's say, and then they eat 800 calories, a very low calorie, like 1,000 calories of just like not so healthful, but very ultra processed foods, and all of a sudden they reverse their type 2 diabetes. Oh, that's medicine,
right?
I guess,
but you're not adding in food as medicine, though.
No,
you know what I mean?
you
are making dramatic dietary changes. Now we could argue, because what you're talking about, really, the evidence for that comes from meal replacement shakes, right? Mm-hmm. So some of the best evidence we have for nutritional therapy, truly using food as medicine, is actually replacing food with meal replacement shakes while still eating vegetables, though.
Most would consider that not to be a super healthful dietary pattern. We would, of course, because love meal replacements.
And that's where the data are the data. Like, don't shoot the messengers. Like that is what they shows. And meal replacement strategies in a prescriptive manner have the best data for weight loss and diabetes remission.
We don't make money from Slim Fast or what are these other companies?
Premier is one of my patients.
But that's not like, it's not even not known as like a meal replacement company. I'm thinking about these other meal replacement companies. We don't make money either way. We don't make money from them. Are they around?
They're around. Anyways,
what are they? Nestle, all these other.
Yeah.
So anyway, that's the concept. Anything else we need to add to this discussion? So in general, we think lifestyle first in terms of primary care and health care in general is extremely valuable. Yeah. There's nobody that's going to push it more than we are.
Yeah. And it really does need to be the foundation for population-based health. That's why it needs to be in primary care, because everyone needs to see primary care docs anyways.
They should.
So that's where it needs to be. So I guess my ask would be for anybody who listens and anybody who's going to pass on anything is, how can we help encourage healthcare systems to incorporate optimizing individual and family, community, lifestyle, behavioral therapies on the front line? Let's help our primary care colleagues out do that. They can't do it themselves, and they shouldn't have to go to a special clinic to do it.
So you don't, and I personally don't think you need a specialist to do it. Honestly, I don't think. No. Is food medicine? That's debatable. I would say, food's not necessarily medicine, but dietary patterns fall in line with lifestyle.
Absolutely.
Exercise, though, I think
exercise is a little bit more like medicine.
I could argue exercise more as medicine, because a normal person has to eat every day. A normal person doesn't have to go do certain types of exercise every day
to survive, but it can optimize their health for sure.
But it could be very prescriptive for certain disease states. So anyway,
all the way down to other things. I mean, again, like smoking cessation. If people smoke, that's a huge deal. Or, other drugs that might be detrimental. That needs to be addressed on the front lines.
Yeah. All right.
Cool.
Give us a review. Give us a share. Share this with somebody who's like, hey, this doctor just writing prescriptions without even talking to me about my sleep and diet and exercise stuff. Yeah, give this out and have some people discuss it.
Let's encourage more of our team members, dietitians, exercise physiologists, behavioralists. We need to
great.
Collaborate more.
Very good. Here's our outro.
This podcast is for entertainment and education and information purposes only. Remember, the physicians on this podcast are not your physician. It should not be considered professional or personalized medical advice. It should not be used to replace speaking with your physician or medical professional to discuss your specific health concerns. The topics discussed should not be used solely to diagnose or treat any condition. As a result, we are not responsible for any unwanted medical outcomes. The views and opinions discussed are of those of the host only and do not represent those of any other entities.